Hi everyone. So we're now going to continue our discussion on musculoskeletal problems, and this content is primarily from chapter 63. So the first topic we're going to go over is osteomyelitis. So right away you're noticing that this is an infection, and specifically we're talking about the bone. So several types of conditions in chapter 63 that we're talking about. So specifically osteomyelitis, osteomalacia, and osteoporosis. So they're all dealing with the bone in some way, but the manifestations that you're going to be seeing in some cases are a little bit different. So you want to be focusing on what it is that is different about each of these conditions. So we're looking at the medical management for all of these three conditions, and then we're applying the nursing framework basically to figure out how can we best take care of this patient. So in terms of the etiology and pathophysiology for osteomyelitis, so it's an itis, it's a severe infection of the bone marrow, and the surrounding soft tissue. At this point, you guys are very familiar with what the soft tissue is. The most common microorganism is the Staphylococcus aureus, but it can actually also be caused by other organisms. In particular, you can have things like E. coli, you can have Pseudomonas, and even Salmonella. All of those are other culprits that can actually be a problem. So under osteomyelitis, you're going to see that they break this down as either being an indirect entry, and they call that hematogenous. And basically, when they're saying that something is an indirect entry as to how somebody got the osteomyelitis, it means that it came from another source. So it's something that's coming, let's say, from the blood, and then it's going to the bone. All right. So one of the microorganisms is traveling from the blood, and it's going to the bone. So it's bloodborne, it's from another site of infection, and it actually usually happens in bone that is traumatized or bone that has lowered resistance. So potentially this can be even in patients that have a diminished immune system. So most often affects children less than 17 years old. The risk factors in older adults under the indirect entry, so it's the older age, patients who are debilitated, and that just means once again that they're weak or they have a diminished immune system. Patients who are on hemodialysis, there's a lot of waste buildup that builds up in the body because the kidneys are not filtering properly, patients are not urinating, so all of that is not good for bone health and bone development as well. And last week we talked a little bit about how uh, patients that have kidney disease are not able to synthesize the active vitamin D, and therefore that becomes a problem for these patients. The other example is patients that have sickle cell disease. So here you're having red blood cells that are basically misshapen. There's a shortage of the good red blood cells, and the ones that they have, they're in a sickle shape, and they're not the best in terms of making sure that the patient is getting all the red blood cells that they need. And you may have covered sickle cell, hopefully maybe in peds. And obviously, IV drug use, that's just a route of infection, right? And that's how somebody can end up getting any of those pathogens that we mentioned. And the vertebrae is the most common site of infection in adults. That just means the bone that is can be affected. For the direct entry, so this one primarily happens in adults as well. Um, And for this one, it's an open wound. So you're being given examples of how somebody may get a direct entry infection of osteomyelitis. So this is an open wound, so a penetrating wound, fractures or surgeries. There's a wide open wound that's sitting there, and that's how the patient gets the infection. So maybe there's a foreign body presence, like an implanted prosthesis, and then maybe that gets infected as well. Maybe when even when the patient's having surgery, they're contaminated, during the surgical procedure, and now you have this prosthetic device that's in the patient's body and it's contaminated. Um, Feet of patients with diabetic or vascular disease, ulcers, right? So those are open wounds there as well. Hips or sacrum near a pressure injury. So just having a pressure injury site, and then the hips themselves would also be the areas that would be affected. So for the direct entry, they're saying that here generally multiple organisms are involved. So there is a chart in your book that you can look at just to get a sense of some of the other microorganisms. But like we mentioned already, Staph aureus was one of the biggest ones. So in terms of the pathophysiology, so keeping this very simple once again. So remember how I told you that the bone is really not the most vascular area, right? So you have this, let's get a marker here. So you have this periosteum, which is basically a dense layer of vascular connective tissue that's covering the bone. So dense layer of vascular connective tissue that's covering the bone. So the microorganisms enter the blood and they grow. And then with that, you're getting an increased pressure in the bone, leading to things like ischemia and vascular compromise of that layer. All right. And the importance of this periosteum is that it is incredibly important in repairing and regrowing bones. So what happens is an infection spreads, it goes to the bone, the cortex, and the marrow cavity. And with that, you're getting an obstruction of blood flow, and potentially can get things like necrosis. So all of this necrosis is leading to things like ischemia, and then you're getting basically bone death, or the bone cells basically dying off. So once that blood flow becomes blocked, we cannot get to that infection that's deep in the bone, right? That dead bone that's in that dead bone and that dead tissue that's inside basically ends up separating from the living bone, and it forms this weird thing known as sequestra. Okay. Um, but the bone, some of the healthy bone tissue still thinks, okay, well, you know what, we're still a bone, we're still getting nutrients a little bit, and we're going to still form bone anyway. But the problem is you have this weird funky thing deep inside that we can't get to, right? So what happens is the periosteum with the blood supply, because some of it is blocked out for sure, it's compromised. Remember this word, compromised. So the part of it that still has some type of blood supply ends up forming a new bone known as the involucrum. And the problem is, in order for you to get to this sequestra, you basically have to now go through this involucrum to treat the patient properly. And that's why you're going to see that in bone diseases that have really bad infections, debridement is definitely part of the treatment. So with regards to the sequestrum, not pronouncing that properly at all. What's going to happen is you're going to get white blood cells and antibiotics trying to travel through the blood to get to that sequestrum that's formed, but they can't do that because the blood flow basically has become obstructed in some way. So the sequestrum basically becomes a reservoir for microorganisms that can spread to other sites. And if it's not resolved or surgically debrided, what that whole area ends up doing is it builds a sinus tract, which may develop, and the patient ends up with this chronic, purulent cutaneous drainage. So all the sinus tract is a passageway, or like tunneling. So I don't know if you've done wounds previously in other courses, but they end up if you've ever taken care of a patient, like in nursing homes or something like that, you see that they have what is known as a sinus tract, and it's called tunneling, and it drains some really funky, nasty stuff that comes off of this sequestrum that's basically developed. So here you are having an explanation of everything we just finished talking about. So this is your initial site of infection, all right? So it doesn't matter how it happened, but whether it was direct or indirect, whatever, it doesn't matter. Patient has this initial site of infection. And this is a periosteum, and we know that it's a connective layer of tissue, and it's also beneficial with bone growth and regeneration, all that good stuff. So now, after this infection starts to get worse in some cases, or the blood supply gets blocked, now you're getting this pus formation that's happening because of the fact that the blood supply is basically being blocked. So the infection is getting worse. It's getting nasty inside there. All right. And with that, you're going to get potentially a tunneling thing that happens. And you can see that in the patient. All right. And here you're seeing that. So now this is further deep in. So this is maybe a week later or whatever it is. And now you're seeing that the sequestrum is the dead bone way deep inside. And you have this involucrum, which is a new bone formation that's still formed over this whole sequestrum, but still there's a pus escapage happening through the tunneling. So not overthinking any of this, just understanding that really because of the sequestrum, which is a dead bone, and the fact that you get a new bone formation over the dead bone, that's why treatment is incredibly difficult in osteomyelitis. So now we're going to get into the difference basically between acute and chronic. And so you kind of want to pay attention to some of the things that are a little bit different among some of these, right? So acute osteomyelitis refers to the initial infection or infection that lasts less than 1 month in duration. So it's the first time the patient is getting an infection. They're going to call that an acute osteomyelitis, or if the infection is lasting less than 1 month. Don't overthink this. This is just exactly how they want to define it. Yeah, I know it can be really confusing sometimes. And some of your local manifestations you're going to be seeing under acute, so paying attention that now we're under acute, are you're going to be seeing things like constant pain that worsens with activity, is unrelieved by rest, swelling, tenderness, warmth, and restricted movement of the affected part. So this is just the local manifestations that are going on. And the systemic, and at this point I want you to really start paying attention to when you're seeing words like systemic manifestations, because you're going to be seeing systemic manifestations under rheumatoid arthritis, and they're all pretty much the same. Keyword you're focusing on is systemic, so the whole body in some way is involved, right? So you're seeing things like fever, night sweats, chills, restlessness, nausea, malaise, right? So temperature elevations, the fact that the patient can't sleep, the fact that they're restless, that's almost like a neurological type of manifestation. The fact that they're nauseous, that's like a GI manifestation. So in some way, your whole body is responding in some way. So under systemic, we're noticing that, temperature is a big deal. That's why we're getting the fever and the chills happening here. And then some of the late systemic manifestations are the patient actually getting a drainage and getting that sinus tract, or even getting things, getting drainage from the cutaneous sinus tract or from the fracture site. But the key word is that late they're getting drainage of some sort. So whether it's from a tract or whether it's a fracture site, but this drainage thing is happening. So under chronic, just to make things interesting, this is an infection lasting longer than 1 month, or an infection that failed to respond to initial antibiotic treatment. So our job is not to figure out whether it's acute or whether it's chronic. Once the patient is admitted, the physicians will assess the patient and they'll say, okay, the patient has acute osteomyelitis, or they'll say, okay, this patient has a chronic osteomyelitis. So therefore now, for us, we should know that, okay, potentially this patient has had this infection for more than a month, or they tried to treat it and they've given the patient antibiotics and it's failed to respond. So at this point, it's not responding. So now we're considering this condition to be osteomyelitis. So therefore, let's see what the care is going to look like. All right. So for chronic, it can be because of a continuous and persistent process as a result potentially of inadequate acute treatment, or a process of exacerbations and remissions. So for whatever reason, maybe a patient keeps getting infected over and over again. Let's give the example of somebody who uses drugs, right? And so no matter how many antibiotics a patient's being given, the medications never even get a chance to work because the patient is always reinfecting themselves in some ways. So there's always this pattern of exacerbations and remissions that may be happening. So this is just a picture of a chronic osteomyelitis of the femur, so deep in there, so really, really nasty, not very good looking. So under the clinical manifestations for chronic osteomyelitis, you're seeing that the systemic manifestations are reduced, all right? So maybe that supreme intense inflammatory response is not as aggressive at this point. It's a chronic situation. However, you're seeing that the local signs of infection are more common. So here you're seeing things like constant bone pain, swelling, and warmth at the infection site. So paying attention to the things that are being highlighted in red and getting a really good sense of, okay, under acute, what was I seeing? And then under chronic, what am I seeing? Right? Um, Over time, granulation tissue turns to avascular scar tissue, which is an ideal site for microorganism growth because it cannot be penetrated by antibiotics. And we have explained how all of this happened with like sequester formation potentially that can happen. So long-term clinical manifestations and complications. So these are rare. So if your patient has osteomyelitis, whether it's acute or chronic, doesn't really matter. These are some of the complications that can happen. So they can have things like septicemia, right? So this is bacterial infection, it's bloodborne, and really the way they try to treat this is with IV fluids and antibiotics. But it's a really horrible situation for the patient to be in because they're going to be having things like fever and chills, like really, really a big problem and very dangerous problem. Your patient can have what is known as septic arthritis. So this is a painful infection in the joint that can come from germs that travel through blood. So examples given are things like Staphylococcus aureus. And the way that you're going to treat that as well is maybe they may have to drain the joint and then they may have to give the patient some antibiotics. So pretty much under osteomyelitis, antibiotics are across the board. The other things that can happen is a patient can have what is known as a pathologic fracture. So this pathologic fracture is a fracture that's basically caused by disease, not injury and trauma. So it's a fracture caused by disease, not injury and trauma. So some conditions basically weaken the bone. So maybe your patient has a tumor or has cancer or something like that. And that would be a perfect example of why this patient is ending up with the pathologic fractures. The amyloidosis, so for this one, it's abnormal protein produced in the bone marrow. It builds up in the tissues and organs and can potentially lead to organ failure. It's a type of plasma cell dyscrasia, just meaning that the plasma cells are not in their normal formation. So this is another one as a complication that can happen. So not overthinking any of this, but knowing that for sure under osteomyelitis, there are all these complications that can happen with the patient. So there are several diagnostic studies that can be done for the patient. And I gave you guys some assignments, and we are going to talk about some of these on Wednesday to kind of just get a sense of what is happening with the patient. But very loosely, so you're going to be doing things like a biopsy, so bone or soft tissue biopsy, and that's a definitive way to identify the causative organism. 1000% makes sense, right? You're doing blood and wound cultures, right? You're doing WBC, and that's usually increased, and you're looking at the ESR, so that one may also be increased. You're looking at C-reactive protein, and that's high with an infection as well. Then you're doing also x-rays, but it's important to remember that signs of osteomyelitis do not appear on the x-ray until 2 to 4 weeks after the initial clinical symptoms. So you're not going to wait to use the x-ray as your definitive diagnosis, because then it's going to be too late. So the other things that they're going to be doing are doing a CT scan, which is helpful in assessing the extent of the infection. But in terms of the early sign of osteomyelitis, they're going to be doing the MRI, because that may be more sensitive than the CT scan in detecting the bone marrow edema that's happening there. All right, and then the bone scans showing abnormalities, they show abnormalities earlier than x-rays as well. And then the radionuclide WB scan, they help pinpoint the area of infection. So with this one, what do they do here? So patient gets a radioisotope, and basically that radioisotope is radioactive. It's like a radioactive material that basically gets tagged to the white blood cells when it's injected into the body, and then they're able to see the inflammation that's happening. So they're able to assess for infection, and they're able to look for any abscesses in the soft tissue. So just knowing that that one is out there as well, and they can use that for diagnosing. So for acute osteomyelitis, so now we're back to acute, and we're specifically targeting some of the treatments that need to be done. So aggressive is a key word. Prolonged IV antibiotic therapy is a treatment of choice if ischemia has not yet happened. Because if the area is ischemic and we can't reach the area, then we probably need to be doing surgical debridement. All right. So cultures or bone biopsy should be done if possible before the antibiotics. It's helpful, right? Get the cultures and you know what the organism is, and then you can target that organism. Initially, maybe they can give like a broad spectrum antibiotic if they need to, if they're not sure, but you always want to get the cultures first before you give your antibiotics. And like we said, surgical debridement and drainage of abscess if needed, right? So if ischemia has already happened, then we're going to have to do the surgical debridement first, and then we can go ahead and give our antibiotics, just because otherwise our antibiotics won't get where they need to be at. So how long? Oh, this was a part of a case study, which I didn't add here for you guys. But anyway, so like let's say somebody was having acute osteomyelitis and their name is VR. Like how long would they need to be staying on IV antibiotics and why? So this patient would at least be on antibiotics from 4 to 6 weeks minimum. And the reason being that the infection of the bone is difficult to treat because of lack of vascular supply and potential walled off dead necrotic tissue, the sequestrum. All right, so about 4 to 6 weeks minimum. And we are going to be giving our IV antibiotics, preferably via the central venous access device. And so that may be started in the hospital, and then it's going to be continued at home. So maybe a patient has a PICC line in place, right? And we get that put in, because if it's for 4 to 6 weeks, they're not going to be in the hospital for 4 to 6 weeks, right? At some point, that patient's going to be discharged to home, and then maybe they'll be getting a nurse, visiting nurse at the house, or if they are at a skilled nursing facility, there'll be a nurse there as well that will be taking care of that patient. So you're giving your antibiotics for 4 to 6 weeks or longer. And some people may actually need 3 to 6 months, apparently, depending on how complicated the case is. So there's a whole bunch of different antibiotics at our disposal that we can use. So you see some of those being mentioned here, and gentamicin and clindamycin and vancomycin. Ceftriaxone even are some of the more common ones that are used. So you do want to look up your gentamicin in the textbook to get a sense of all the nursing implications under that particular medication. For the chronic osteomyelitis, so this is 1 month or longer, or they were doing treatment, but it wasn't working to the best of their ability, right? So for this one, it's surgical removal of poorly perfused tissue and dead bone, and we're doing extended use of antibiotics. So maybe even Cipro would be one that we're giving the patient. So IV and or oral up to 8 weeks. And they're assessing whether or not the antibiotics are working with bone scans and ESR testing. They can give what are known as acrylic bead chains that contain antibiotics, and they can actually implant those into the wound to basically help with infection. So those beads can actually be left in, or they can be taken out depending on what the physician wants for the patient. All right. And then they can also have intermittent or constant antibiotic irrigation of the bone may also be done. So this is under chronic. So basically, pretty much an extension of what would have happened under chronic, but now we're just going a couple more steps further. All right, so with interprofessional care, so what type of nursing care is this patient going to require? And medical care, actually. So maybe caths or braces to protect the limb or the surgical site. Maybe the patient will need things like negative pressure wound therapy. And we can talk some more about the negative pressure wound therapy when I see you guys on Wednesday. But all it is basically just a wound vac. And they put like a special dressing and foam over the wound. There's a tubing, and then there's like a vacuum pump at the end of it all. And basically, all the moisture and the secretions are getting tunneled into that wound vac pump that they have, right? With regards to the hyperbaric oxygen therapy, so that's just giving the patient a lot of oxygen. So they're in a hyperbaric oxygen chamber, and they're getting 2 to 3 times higher than normal air pressure. So under those conditions, the lungs can gather much more oxygen than would be possible, breathing pure oxygen at normal air pressure. And when the blood gets all this extra oxygen throughout the body, basically that's helping to fight bacteria and stimulate the release of growth factors and stem cells and all of those types of things. You may have heard of hyperbaric oxygen therapy for athletes. They do that just to pump up their oxygenation and their stamina before they're getting ready for big races or big bike races potentially, right? So some of the other things that may need to happen is things like removing of prosthetic devices. Maybe a patient needs muscle flaps or skin grafts or bone grafts. Maybe a patient may even need an amputation, right? So all of this is just considered interprofessional care. In terms of your nursing assessment, so you have several charts in your book, and once again, it's just collecting all the information, whether subjective or objective, and trying to figure out how the patient is presenting to you. So getting the past health history, have they had any bone trauma, open fractures, open or puncture wounds, other types of infections, getting all of that. Have they used antibiotics before? Have they ever had any bone surgery? Just getting a really aggressive and comprehensive nursing assessment of the patient. All right, under the different categories for subjective data collection. So seeing under health perception, health management, seeing whether the patient has had any IV drug and alcohol abuse, right? Under nutrition and metabolic, looking at whether they suffer from anorexia, weight loss, or chills. Activity, finding out about weakness, paralysis, muscle spasms. Under cognitive, perceptual, any local tenderness, increase in pain, and then under coping and stress tolerance, whether or not there's things like irritability, withdrawal, dependency, and anger. And a lot of these are pretty self-explanatory. I think you would think of these things by yourself too, just when you're taking care of your patient. And then under your objective data, some of the stuff you'll be looking at, so general stuff, whether they're restless, whether there's any spikes in temperatures, whether the patient is suffering from things like night sweats, Under the skin, diaphoresis, erythema, warmth or edema. Under musculoskeletal, any restricted movements, wound drainage or spontaneous fractures. And then under the diagnostic findings, so these are like your lab data, included here as well. So any elevated WBC, any positive cultures, elevated ESR, presence of sequestrum and involucrum. So just doing a really, really good assessment for your patient. And this is not the first time you're coming across the difference between subjective and objective data, but you're making sure that you're looking at everything so that you're managing the patient properly. And then under nursing diagnosis, and trust me, these are going to be very similar across the board under musculoskeletal. So things like acute pain, you're seeing that that's at the top. You're seeing things like impaired mobility, and you're seeing things like lack of knowledge, right? And then you also have a care plan and page 1480 in your text that you kind of want to be looking at as well. So overall goals, pretty straightforward. So you're looking at your nursing diagnosis and then focusing them accordingly. So if it was about pain, you're going towards pain, right? Complications associated with osteomyelitis, for sure, we don't want any of that. So no complications. Adhering to the treatment plan and then maintaining a positive outlook on the disease. Under health promotion, so controlling other current infections, and you are paying extra attention to any patients that have other comorbidities. So patients that are maybe potentially immunocompromised, patients that have diabetes, orthopedic prosthetic devices or vascular insufficiency, and just really, really assessing your patient in a really, really comprehensive manner. So acute care, so immobilization and care for handling of affected limb to decrease pain and risk of injury. Some of this sounds very familiar. Assess and treat pain and muscle spasms, right? So we have a whole bunch of medications that we can use at our disposal. So things like NSAIDs, opiates, muscle relaxants, and also using some of the non-drug approaches. So whether it's meditation, deep breathing, all of that comes into play here. And then dressing care using sterile technique, that goes without saying, proper positioning, support of the extremity, preventing complications of immobility. So, giving your patient range of motion, encouraging them to do even the isometric exercises, whatever that looks like for your patient, but making sure you are addressing it, because the last thing we want is for the patient to be really, really immobile, and now they can have other complications from that. And so other things with regards to antibiotic therapy. So medications, specifically under musculoskeletal, these antibiotics, they're really, really damaging to things like hearing, your kidneys, and they can cause problems like neurotoxicity. So one example is the cephalosporins, something like cefazolin would cause things like hives, severe watery diarrhea, bloody stools, in the throat and mouth sores, and then the fluoroquinolones will cause things like tendonitis or tendon rupture. So incredibly important about monitoring the peak and trough levels. So I'm really interested in hearing from you guys how we get the peak and trough levels. And you want to look to see whether any of the medications I gave you are asking you to be doing your peak and trough levels as well. So lengthy antibiotic therapy can cause an overgrowth of Candida albicans and C. diff, particularly in the GU and GI tract, especially if the patient is immunocompromised and older patients. So key word is lengthy antibiotic therapy. And the other keywords are immunocompromised and older patients. So lengthy antibiotic therapy, and especially in the immunocompromised and in the older patients. So not everybody's going to end up with an overgrowth, right? It's just in some patients you are going to be incredibly careful, and that is why they tell the patients use antibiotics only as ordered. Don't double up your doses, don't skip doses, don't do any nonsense with the antibiotics, because if the patient doesn't follow the protocol properly, Potentially, if they even try to give it to them at a later date, they may not even work against the infection that they are trying to treat, right? So the importance of following the proper medication regimen. All right. So teaching the patient to report any changes in the oral cavity. So in particular, whitish yellow curd-like lesions or the GU tract, perianal itching and discharge, right? So pretty bad type of manifestations that can happen on because of lengthy antibiotic therapy. So patient and family are often anxious and discouraged, so you need to be giving them continued psychological and emotional support. So for sure, the patients that are most likely to be getting the lengthy antibiotic therapy are the ones maybe that have the chronic osteomyelitis, because we need to be treating them for longer as well. And then under the ambulatory care, so management of their CVAD devices at home and follow-up testing, making sure that they're understanding the entire antibiotic prescription. We have the wound care and dressing changes, and then we're continuing to provide physical and emotional support to the patient. All right. And after we've done all that we've done, so we were remembering once again what our goals were, right? So patient having satisfactory pain management, adhering to the recommended treatment plan, showing a consistent increase in mobility and range of motion, like really, really making sure that our patient is okay. So this is under osteomyelitis. I think I'll end here and I'll make them 3 separate audios. That way it's just easier and it's not just like one long drawn out audio. So under osteomyelitis, we're understanding that it's an infection of the bone. We're understanding that it's very difficult to treat. We're understanding that there's acute and chronic manifestations that can happen. We're understanding what sequestrum is. We're understanding that the particular antibiotics that we can use, and some of them, or most of them, are going to be asking you for a peak and trough. We're understanding that antibiotics are the major mode of treatment. And we are understanding that things like debridement, anxiety, nervousness, whatever, depression can happen with the patients depending on the particular body part that's involved. All right, so that's it. I'll stop here.